function for those patients. So management of unmet need in DME require a treatment option that provide maximum sustained visual gain, as well fewer injection than the current anti-VEGF treatment. And this will benefit the patient, physician, as well the healthcare system. So I'm sure all of us will have those patients in our clinic. And today I have example of a patient that I faced last week in my clinic. First case is a 30-year-old uncontrolled insulin diabetic patient. She presented with metamorphopsia and blurred vision in her left eye. She never attended any retinal screening because she's already a mother, busy with family, and she managed only to go to her endocrinologist, unfortunately, treatment follow-up. And she lives almost 2.5 hours away from Abu Dhabi. Her best corrected visual acuity is 20/20 right eye, 20/40, pressure is normal, anterior segment is normal. This is a fundus photo of the patient, and you can see she has multiple deposits. She's already, as well known, dyslipidemic without under-treated dyslipidemia, unfortunately, and under-controlled diabetes mellitus. And this is her OCT. The right eye, she started to have non-foveal diabetic macular edema. Left eye, she has already this subretinal fluid, as well intraretinal hard exudates. So I discussed with the patient that she needs to attend her appointments, and we need to start treatment of her condition. As well, she will be a long-term patient that she needs to come with us very often, and she needs to receive the proper treatment of her condition. And this is the first example. Second example is a 65-year-old female, non-case of regressed proliferative diabetic retinopathy that has been treated with PRB, and she received multiple injections. This is her fundus photo. You can see she bled already, and there is reactivation of her proliferative diabetic retinopathy. So this patient, she missed almost 4-month appointment. When I asked her what happened, she said she was admitted in the ICU. She had pancreatitis complicated with septicemia. So she had been admitted in the ICU for almost 2 months, and her blood pressure, her blood glucose were uncontrolled. Everything were uncontrolled. That's why after she was stabilized, she came back to us. And you can see this is her OCT. Unfortunately, we tried to discuss again the need of proper treatment. We tried to discuss again the need of rescheduling, and to make sure that she will be able to attend her follow-up for treatment, as well for monitoring of the disease. Those are 2 different patients with different diabetic macular edema. The one on the left side of the monitor, it's a single eye patient who lost his other eye because of neovascular glaucoma. And what is special with this patient, he's a 75-year-old male who likes to travel to Saudi Arabia and to stay there for almost 6 months. And he will never attend any of his appointments. So I tried to convince him to start at least some sort of treatment now, and we try to monitor his good eye. His vision is 20/40. But those patients, especially single eye patients, we need to be careful with them. We need to explain for them the need of proper treatment. And as we can say again, for sure, durable, more efficient treatment will help those patients. The other one is another patient. He is uncontrolled diabetic type 2, 38-year-old. His insurance, unfortunately, is not covering his treatment, and his vision 2100 in that eye. And the insurance, although we submitted multiple requests to start anti-VEGF treatment, but insurance did not allow us to start the anti-VEGF treatment because of different issue. This is another patient with DME, very chronic DME. And this patient, he will show only once or twice a year for his ophthalmology treatment because multiple other comorbidities that he need to to attend. He does renal dialysis 3 times a week, as well different cardiology appointments. So he doesn't have the time to come and attend his appointment, and you can see how chronic is his DME. I'm sure all of us, we have those patients. As a physician, we would love to help them, but unfortunately, we don't have the resources, and unfortunately, we need something that will help those patients to be able to meet their better visual need. Thank you so much.
Thank you very much, Dr. Noura, for this interesting and excellent presentation. But because we are over little of the time, so we can move to Dr. Firas. Maybe at the end, after Dr. Firas, if we have a time, we can discuss. There is many points you are highlighted, and maybe we need so many people, they will ask about it. Dr. Firas, now I have privilege to introduce Dr. Firas Jallouk. He is a vitreoretinal surgeon in Mediclinic Abu Dhabi. And he is going to talk about DME challenges and opportunities. Dr. Firas.
Thank you, Dr. Mohammed.
مرحبا.
Okay, can you see my screen?
Yeah, please, you can go ahead.
Oh, thank you. Okay, so we'll talk about diabetic retinopathy today, stay in this theme of diabetic retinopathy and diabetic macular edema. Also going to talk about the new treatment, as Dr. Noura said, about to minimize the burden on patients and doctors and health system. So overview about diabetes and diabetic retinopathies and diabetic macular edema. Patients with diabetes are at increased risk of several comorbidities and chronic conditions. They're suffering from either macrovascular complications, including strokes, cardiovascular diseases, or microvascular complications where retinopathies are coming under. Vision loss is the most feared complication of diabetes. Loss of visual acuities actually affects normal daily activities that a person can perform, and we must always remember that this disease affects patients at working age. So diabetic retinopathy is a common progressive macrovascular complication of diabetes and is a precursor to progressive diabetic retinopathy and diabetic macular edema. And we have 50% of patients with very severe non-progressive diabetic retinopathy progress to progressive within a year. Almost 25% of patients have proliferative diabetic retinopathy after a diabetes duration of 15 years. While diabetic macular edema may occur at any stage of diabetic retinopathy, it is more likely to manifest following a severe non-proliferative diabetic retinopathy. The correlation of diabetes duration with any type of diabetic retinopathy, the duration of this among younger onset patients with diabetes, the prevalence of any retinopathy was 8% at 3 years, 25% at 5 years, 60% at 10, and 80% at 15 years. The prevalence of progressive diabetic retinopathy was 0 at 3 years and increased to 25%, quarter of those patients at 15 years. Visual acuity tends to decrease with increased in the severity of retinopathy and duration of diabetes. Around 80% of patients with type 2 diabetes for more than 15 years have retinopathy, of whom 5% have vision-threatening diabetic retinopathy. The clinical feature of DME is microvascular damage, breakdown of the inner blood-retinal barrier, increased permeability of retinal blood vessels, leakage of fluid from blood vessels, and that would cause macular edema and blurry vision. Risk factors of diabetic macular edema: high blood pressure, increased total serum cholesterol, long duration of diabetes, as we said, and drug-induced diabetic macular edema. All diabetes related and ocular comorbidities were significantly more prevalent. Diabetes related comorbidities, renal diseases is very at the top. Also, if you see on the ocular comorbidities, the proliferative diabetic retinopathy and non-proliferative diabetic retinopathy. So as Dr. Noor said, pathophysiology of diabetic retinopathy and diabetic macular edema is multifactorial ones. So it's inflammatory, vascular, and neurodegenerative. So diabetes that causes hypoglycemia, oxidative stress, which would lead to inflammation, vascular pathology with pericyte loss, and neurodegenerative, and that would lead to loss of breakdown of blood-brain barrier, which would cause diabetic retinopathies, either proliferative or diabetic macular edema. I'm just going to take a minute talking about VHFs, vascular endothelial growth factors, which is an important factor in the development and progression of proliferative diabetic retinopathy and diabetic macular edema. And now this is the main target of all new medications, most of them mainly. So the microvascular changes that would lead to hypoxia, which would lead to increase in the vascular endothelial growth factors, and that would lead to neovascularization, visual loss, and to macular edema because of the increased permeability. The VHF signaling impacts ocular macular vasculature. VHF is a potent vasopermeability factor. Its expression in the retina is regulated in response to ischemia and hypoxia. VHF simulates a response by binding to VHF tyrosine kinase receptors, which induce an intracellular signaling cascade. Downstream ocular effects of VHFs are increase in retinal vascular permeability and endothelial cell proliferation. Breakdown of the blood-retinal barrier results in retinal edema. Patients undergoing intraocular surgery, they have higher VHFs, and patients undergoing cataract surgery, they also do have higher VHFs, which something we can see over, well, sometimes after cataract operation, increase of diabetic macular edema. And patients with various forms of macular edema, here you can see the increase in the VHFs, both in diabetic retinopathies, diabetic macular edemas, and vein occlusions. So VHF-A levels are elevated in diabetic retinopathy. Retinal VHFs are elevated in experimental diabetes. Increased VHF-A levels are found in vitreous of eyes with proliferative diabetic retinopathy. So diabetic retinopathy patients have higher aqueous VHF-A levels. So VHF upregulation, hyperglycemia, cytokinase, and hypoxia and growth factors, they all will increase VHF's upregulation, which will lead to either neovascularization, which will lead to proliferative diabetic retinopathies, or breakdown in the blood-retinal barrier, which would lead to diabetic macular edema. So diagnostic tools of diabetic retinopathies, I'm not going to spend much time on this. I think the gold standards now for DME is OCT. Diabetic retinopathies and diabetic macular edema treatment. Systemic factor control is very important. Available ocular treatments to prevent vision loss or improve vision, either laser treatment, anti-VHF therapy, which improves visual acuity, effective treatment for central involved macular edema, steroids associated with ocular. Now, laser photoablation for diabetic macular edema, I'm not sure how many of my colleagues still doing laser treatment for macular edema. I think I'm doing less and less by the time. I can't remember the last time I did it. Now, clinical benefits of anti-VHFs has been demonstrated in diabetic retinopathy and diabetic macular edema in a number of clinical trials. So for ranibizumab, the DRCR-NET protocol, DRCR-NET, protocol T, Resolve Restore, and protocol S, which showed greater best corrected visual acuity improvement and greater reduction in central retina thickness versus laser in treating diabetic macular edema. That was in the DRCR-NET protocol T. Non-inferior to pan-retinal photocoagulation at 2 years in treating proliferative diabetic retinopathy. It's in protocol S. less conversion to vision impairment, impairing diabetic macular edema, and less loss of visual field with ranibizumab treatment compared to preventative PRP in Protocol S. Aflibercept, also in Vesta Vivid, DRCNet Protocol T in Clarity. And the one I'm going to talk about at the end of this talk, brolucizumab, the new kid on the block. There's the new two research studies, Kite and Kestrel. It's still under approval for diabetic macular edema, but it's very well worth thinking about and looking forward to, for that matter. So treatment options provide maximal and sustained visual acuity gains, requires fewer injections and less monitoring than current treatments. In summary, diabetic retinopathy and diabetic macular edema are vision-threatening complications of diabetes. Patients with diabetic retinopathy or diabetic macular edema present with complex comorbidity profiles and require long-term treatment. VEGF plays a key role in the development and progression of peripheral diabetic retinopathy and macular edema, and therefore presents an important therapeutic target for both diabetic retinopathy and diabetic macular edema. Advanced diagnosis tools and anti-VEGF therapy have revolutionized the diagnosis and treatment in diabetes. There is a need for treatment option that provides optimal visual outcomes while reducing the overall burden on patients, clinicians, and healthcare providers. I'm just going to talk now about brolucizumab and the new two studies, Crystal and Kite. Now, over the last, it's just worth mentioning before I go through those, that over the last decade and a half, we had a major improvement in the treatment of both neovascular AMD and diabetic retinopathy. But we also learned that we still have unmet needs, which I can put into two categories. One, obtaining better efficacy, and two, attaining sustainability and greater durability of the drugs. So coming back to Crystal and Kite rationale, so the purpose of the global phase 3 trial is to evaluate the efficacy and safety of brolucizumab in treatment of patients with visual impairment due to diabetic macular edema, whilst also offering the potential to reduce treatment burden due to the longer injection intervals. So these are the study participant in both in Crystal is 566 patients, in Kite 360. Primary object to demonstrate that brolucizumab is non-inferior to aflibercept with respect to visual outcome after first year of treatment. So endpoint change from baseline and best visual and best corrected visual acuity at week 52. So Crystal and Kite studies conducted across 36 countries. In Crystal, it's amongst 13 countries. It has 566 patients and 118 sites involved, and it has 3 arms. I'm going to talk about those in a second. While in Kite, it's 23 countries, 360 patients were recruited, 779 sites participated, and it has 2 arms. So I'm going to go through this very quickly. The key inclusion criteria: patients either type 1 or type 2. Visual impairment due to diabetic macular edema ranges between 2032 to 2320. And diabetic macular edema involved in center of the macula with over 320 microns on screening. So Crystal and Kite, both Crystal and Kite are using same parameters for aflibercept, showing at the bottom of this slide as 2 milligrams with loading doses every 4 weeks for 5 months, and then injection every 8 weeks, as written on the label. While brolucizumab, it has 2 arms, either 3 milligrams or 6 milligrams. And I think that's for regulatory requirements. So for the brolucizumab, it has the regime here is to give a loading dose of every 6 weeks rather than 4 till week 24, and then every 12 weeks injection unless there was evidence of disease activities at week 32 and 36 and 48, and then patients will be transitioned to 8 weeks interval. So the primary endpoint in this slide, visual outcome for endpoint for each of the randomized arm primary endpoint was met in both CRYSTAL and KITE, where brolucizumab 6 milligrams achieving non-inferiority to aflibercept 2 milligrams in change of best corrected visual acuity from baseline. And you can see here on both graphs that both are very close. This slide looks at the central thickness changes from baseline with time. And we can see rapid dry effect in both arms of brolucizumab with time, and we can see also drying outcome with each of the arms at week 52. In this slide, this will be looking specifically at the percentage of eyes achieving thickness less than 280 microns at week 32 and 52. We can see brolucizumab achieving this non-inferiority. Actually, and here you can see at week 32, 47 patients in brolucizumab achieving less than 280 microns, where aflibercept 29%, while in KITE you have 48% at week 32 and 30% of aflibercept, while in CRYSTAL at week 52 you have 54% achieving less than 280 microns, while aflibercept achieving 40%. Now, here, few patients on brolucizumab had, and this will look specifically at percentage of eyes achieving, and this will look into more details to fluid compartments in proportion of patients who had residual retinal fluids. So either in subretinal fluid or intraretinal fluid, and you can see that brolucizumab has fewer patients with less either subretinal fluid or intraretinal fluid comparing with aflibercept in all arms. Now, here we'll talk about maintaining of 12 weeks intervals, and you can see that patients maintained on 12 weeks intervals until week 52. In CRYSTAL, it was about 55%, and in KITE it was 50%. And bearing in mind that the design of the study, they switch to 8 weeks intervals wherever they see active disease, which is something we might not do actually in real life practice. Safety profile, it's very interesting here. It was a bit of surprise for me when you see, endophthalmitis in CRYSTAL, there was 0 for brolucizumab and 1 for aflibercept, while in KITE, you can see 1 each, but retinal vascular occlusion was only 1 in brolucizumab in CRYSTAL, and in KITE, there was 1 each in both brolucizumab 6 milligrams and aflibercept. Well, intraocular inflammation, including retinal vasculitis, you had intraocular inflammation. There was 3.7 in the brolucizumab 6 milligrams in CRYSTAL, while in KITE there was similar between aflibercept and brolucizumab, 3 each, while including retinal vasculitis, it was 1 in brolucizumab and 0 for aflibercept. So in summary, brolucizumab 6 milligrams was non-inferior to aflibercept in main change in best-corrected visual acuity at week 52 with fewer injections. Significant improvements in central subfield thickness from baselines were achieved with brolucizumab 6 milligrams. There was a higher proportion of patients with fluid resolution on brolucizumab 6 milligrams at week 52. More than half of brolucizumab 6 milligram patients were maintained on 12 weeks interval treatments up to week 52 immediately after the loading dose, which was 6 weeks intervals rather than 4. Overall, brolucizumab had a well-tolerated safety profile. Safety data in crystal and card shows no evidence that underlying vascular diseases has a negative impact on the brolucizumab-related incidence of intraocular inflammation. Thank you very much. Sorry if I took a bit longer than I was supposed to.
Thank you, Dr. Firas. That was a very nice and excellent presentation. As we are running behind the time, is there any questions or comment from Dr. Anora or Dr. Firas? I think most of us, we're still looking for the ideal way of treatment for the DME, either from the efficacy or the safety or the durations. So as you or both of you mentioned, but we are, moving in the right ways. Every now and then we are finding a new medication that can overcome of certain obstacles that we are suffering of. If there is any comment from both of you, or Dr. Mangata Dogurai, if you want to participate. And I think we are having in the, they are listening to us, Dr. Patricio and Dr. Ayman Medanat. If they want to join us here in the floor, it will be a very great. Yes, Dr. Nora or Dr. Firas.
Well, I just want to pick up, same as what Dr. Anora said about the burden for patients, especially those, we can always see those patients, especially other type 1 patients or type 2, maybe in their working age, they don't show up to their appointments. Those patients, they had appointments with doctors, especially type 1, since they were kids, maybe monthly appointments. They had all sorts of health issues. And if visual acuity is not significantly been affected, then they usually do not show up to their appointments. So if we can find this magic medication where we can give them and it has greater sustainability, then that would be a great improvement in this disease, in fighting this disease comorbidity.
Thank you.
Good evening, Dr. Muhammad.
Good evening, Dr. Ayman. You can be with us. If there is any comment, Dr. Ayman, and you can stay with us. I am happy that you are here.
This is a very interesting session. I want to thank Dr. Anora and Dr. Firas for these interesting presentations. My comment is that it's always to have, it's good always to have a new drug in your armamentarium to treat diabetic macular edema. And looking at the Crystal and Kite study, the safety profile definitely looks better than the Hawk and Harrier study of the AMD. So I'm really optimistic that this drug might be a good addition to treat diabetic macular edema, hopefully, which is a real problem in our part of the world, as all of you know that the incidence of diabetes mellitus in our region is really higher than any part in the world. Thank you very much.
Dr. Ayman, thank you. Can you stay with us, Dr. Ayman, if you don't have any commitment? Also, Dr. Mangata, if you have any comment, last comment before we move to our next part of this meeting.
I just wanted to ask Dr. Firas, because we find that even with the elfibercept, almost 50% of the patients would require 3 monthly dosing. So is it was different? They didn't mention anything about that in the trial. So is it that part has not been looked into?
I think aflibercept in the
AMD maybe, doctor. He is talking maybe, I think AMD.
No,
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 no, I
no,
think
no,
for
on DME. I'm talking
for
DME,
DME,
height
for
and
DME,
Yeah.
for DME, I think I think what they're promoting and what they have is 5 monthly loading dose. They have for 5 injections every 4 weeks. I think that's what the aflibercept, the bio company, what they called in the leaflets, whatever that is. I think their instructions, their guidance for bio is just to have 5 monthly loading dose injections. That's not my opinion about loading dose. I'm not a great fan of loading dose in diabetic macular edema. I don't do it. I don't practice it. Don't promote it. But I mean, that's the studies. They have this 5 loading dose, 5 monthly, and I think that's where the Kristen and Clyde they followed.
Okay, thank you very much. Thank you, Dr. Noura. Thank you, Dr. Firas. You can stay with us, and also if you want to participate with us in the second part, you are most welcome. So we are going to move to the next part of this meeting, and it will be about AMD. And we are here talking about with AMD, and we will have Dr. Mangata Dogra and Dr. Majdi Musa. And I'm happy that Dr. Ayman Midanati can join us, also Dr. Noura and Dr. Firas. So I will give you the, if you can present the first case, Dr. Mangata Dogra, then we will have a discussions about that. Dr. Majdi, you are with us? Okay.
You see my
yes, I can see. Yes, go ahead, Dr.
Yeah. I think I'm going to present quite an unusual case here.
I'm sorry I didn't introduce Dr. Mangata, but he is a well-known now in our area, and we are met a long of time with him. He's a well-known figure of vitreoretinal surgeon, and he's a director of retinal service, Grewal Eye Institute, Chandigarh, India. Dr. Mangata, sorry.
Thank you for invitation and for nice introduction. So I'm just going to go straight to the cases so that we have more time for discussion. And the case one, which I'm going to present, is quite interesting. I just have a financial disclosure that I've consulted to Buyerzitis. And this, I'm talking about a 59-year-old female patient who is a doctor herself, anesthesiologist, gradual diminution of vision, right eye. For the last 3 months, she said she had actually in this eye a recurrent anterior uveitis since 2009. And she was, in fact, actually B27 positive. And also she had a laser treatment like a barrage in 2012, because which was PVD related. So this was her earlier history. So there was no history of any systemic illness. And there is a family history of AMD in mother, as well as now also in father. So that is different, which I just wanted to share. Her visual acuity was good. You can see here 6966. Pressures were good. And because of the uveitis in the right eye, she had some posterior synecdoche and is developing some cataract. So I'm just going to show you the fundus picture as well as the OCT here. So this is the right eye in 2017 when she was having a little blurring of vision. And you can see here that you have a huge PED, pigment epithelial detachment. And so if you look at the left eye, even in the left eye, she is having this kind of a pigment epithelial detachment, which is sort of in 3 lobes here. And so what we see here is we didn't find any neovascular membrane or polyps or anything on the OCTA. And we did that time because we thought we must do the ICG and geography along with FFA combined, but we didn't find any polyps or any network as far as the disease was concerned. And this is the left eye. So was the left eye here. So now you see in 2018, she's still 6'9", and like this. So we kept her under observation, and you can see the PED is huge, and we still don't find anything because the darkness is because of the cataract which is coming up. And the left eye, the PED now they have all joined together. It's a large PED, and top of it, you can see some collection here, and the visual acuity is still 6.9 with correction. And now you look at what happens in 2019. This is the left eye I'm talking. This becomes as big as the other eye. And we have not treated because we didn't find anything else and the vision was good. And we were always scared that if we have a rip, and since the vision was good, we wanted to wait, and she was fine waiting, and she understood being a doctor herself. And now you look at this, this is subsequently also we didn't find any polyps or any branching vascular network or any kind of other abnormalities here. And so was the left eye. You can see where I have shown you, it's a large PED again, but we didn't find anything out there also. And so was the OCTA. We didn't find any sort of a network, either the choroidal neovascular membrane. And you can see we are still sort of watching. And here, because of the cataract in the right eye, the vision went down to 624 because because the nuclear sclerosis, and the left eye was still 6.9. It is not a blood here, but some kind of a pigment which is seen, and otherwise looks like a blood. And you can see the golden ring. It has grown huge, and left eye is still 6.9 with +3. Of course, here the number is plus because it's sort of raised there. And now you look at, now we have further followed it to 2021. So this is the recent picture. So you can imagine this is now 4+ years follow-up. She's still 6.9 in this eye with this correction. And you can see even the configuration has changed. And you can imagine how scared we would be, but the vision was going down, and she understand if there's a rip, even spontaneously or otherwise, it could be a problem. So what happens in the meantime in the right eye? You see, this PD started flattening of its own. We didn't treat it. It has flattened down of its own, and the vision is maintained. She has in the meantime gone, and this is the other eye I have shown from 17 to 21. So my question here is, now, should we wait and watch to treat, especially now left eye? Right, of course, has behaved very well. It has become of its own. You can see how it has the height has decreased remarkably, and the vision is still maintained. So what are the management options available or choice of anti-VEGF agents in such a case? This is quite an intriguing case. Although I have patient whose vision is still preserved, we have not treated, but this is an intriguing case, which in fact, I thought will get a lot of inputs from all of you here. So this is what was my first case. So this is open for discussion.
Thank you very much, Dr. Magada. This is a very nice and very interesting, and I think there will be a lot of debate about this one.
Can I make a comment, Dr. Muhammad?
Yes, this is my question. What will be? What is your opinion, Doctor, and comment, Dr. Majdi?
Thank you very much for this nice and interesting case. This is a very peculiar case. Actually, we shouldn't treat these patients. And there's a recent publication by David Sarraf, 2021. They said that they have many cases like this, and we shouldn't inject because sometimes injection might lead to, rip. But these patients, they consider them as no CNV, as you said, because we did all the multimodal imaging. And this is very important because sometimes you should exclude the CNV, but there is no CNV here. Actually, it's fluid, subretinal fluid, and at the dome of the RP detachment. And it was also mentioned in the literature. And it should be followed up because this is just decompensation of the retinal pigment failure of the pump. That's why accumulation of this fluid. But again, you did the right choice, follow up and keep following up. And unfortunately, these patients, I have one patient like this since 13 years. And once she flattened, we have diffuse RP atrophy and loss of the outer retinal layers. But it's a very peculiar case. You have a bilateral case. My case was bilateral too, and it was injected twice before she was presented to me. Then I followed her up with every mean of multimodal imaging, and I couldn't find any CNV. So again, this is a very good point to raise. There is no need to inject because injection here might be hazardous. There is no need. There is no CNV, and watching and follow up, but careful watching for these patients is very important. And once they flatten, you will see the results. My case flattened both eyes. One of them is counting finger, the other one is 660 maximum because she lost all the outer retinal layers because of the long-term RP detachment. But again, follow-up is the main regimen for this case. Thank you again for this case.
Dr. Majdi, can you stay with us also, and Dr. Mangata? If suppose this patient there is a deterioration of visual acuity, and the same presentation, but there is a deterioration of the visual acuity. And I want to ask also another question. Those cases, there are, for example, their visual acuity may be good, but how is the quality of the vision? Is there is an effect of visual, the quality of the vision? Is there any complaint related to these patients who is suffering of, Mangato or,
that is what I wanted to share. You see, she herself is a professor of anesthesiology, and she's holding a very high position, mostly gave pediatric anesthesia. And she feels that she's not getting disturbed by this. And she feels that her vision is as good, although she also gets very scared looking at this lesion. She feels that something may happen suddenly. So that is different, but she is doing very well. And now it is already close to 4.5 years. So which is a long time, you can see, with such a large PD. And so, because since it has been long period and she's not complaining, and the vision is still, as I said, 6.9, she's maintaining. So we have thought what I'm really thankful to Dr. Magdi for making the comment, and he has seen the similar kind of case that we observed for such a long time, because I had hard time even convincing my own people that why I don't want to treat at time when once it is changing, especially you see how much change has occurred over a period of time. But then I think
please don't.
Yes.
Please don't make your colleagues push you to do the wrong thing. You are doing the right thing.
Absolutely.
Please, because my colleagues always, my case went around for many doctors, and they told me, why you are not injecting? I said, there is no justification for injection. Dr. Al-Amri was asking a very tricky question. If the patient is complaining, even though if the sensory detachment increase, she will complain more. But again, why to inject? There is no need for injection in such cases. Even after injection, I have my case after 2 injections, she had minimal flattening of the RPE detachment, but there is no improvement in the visual acuity. But again, there is no need to treat this patient because there is no CNV. RPE detachment will not regress with intravitreal anti-VEGF. The fluid might decrease or increase with time. It will be fluctuating, but again, there is no need for injection. And even if the patient is asking for injection because of the deterioration of vision, there is no justification for that. Because imagine if you inject a patient like this and you got a rip, that's it. She will lose the vision suddenly. But please prepare this patient for the long-term result, because sometimes they said after they flatten and they get worse vision, why didn't you inject me? You tell her, I gave you 5 or 6 years enjoying your good vision, and this is the natural course of the disease. There is no way to stop it or to regress it.
Yes.
But if there is a fluid, Dr. Majdi, if there is
fluid, there is fluid already. There is
a fluid.
There is fluid, but this fluid is due to failure of the pump of the RPE. Once you separate the RPE from the Bruce membrane, you get fluid because the nourishment of the RPE is coming from the choroid, and you are depriving the RPE. You are failing the pump, but again, it's minimal fluid, even if it increases. The only thing, if she had sudden drop of vision, 5 lines or more, suspect CNV, do OCT angiography, do everything again, and you find CNV, you can do it. If you don't find CNV, you shouldn't do it.
Even if there is deterioration of the vision, even if there is deterioration.
Even you expect that, because separation of the RPE from Bruch's membrane, with time, you will have flattening of this RPE and deterioration of vision and loss of outer retinal layers. With time, it will happen. That's why I'm telling the doctor, prepare her
for that. Yeah, we are looking for that in the right eye, because it has itself flattened. It is almost now kind of, but the vision is still good. So we are looking for that, as well as why we have been doing all the time OCT angiography as well as ICG is to look for any choroidal neovascular membrane developing, any polyps developing, or are we having any branching vascular network or something coming up. So that is why we are also doing additional things, but those things have not happened as yet. So that is a good point. Yes. Thank you. Thank you, Dr. Magdi.
Keep what you're doing. Keep what you are doing, and don't let anybody change your mind, please. This is a very good chance to give a message for the audience.
I had to take that.
And even Dr. Al-Amri, don't let him push you to treat this patient, because the fluid increase, the fluid decrease. There is no need to treat this patient.
No, I'm just trying to reach to the point that we convince everyone with us listening to us in the way how to manage these cases. That's why I think Dr. Mangata is present this case just to highlight about this point, because sometimes when you are seeing this shape of, I mean, a dome shape and a lot of separation, you know, everyone will say, okay, what to do? Even there is one question here is coming, why don't you do a BDT to treat these patients? Is there any role for that?
Sorry to interrupt. Can I ask, is micropulse laser has a role here?
What
Dr. Firas is asking, is there any role of the laser here?
Micropulse laser.
Micropulse.
No, I don't think. The question is, I again come to what Magdi has also highlighted. I think the vision is good. If we have anything happening here, we do something and this develops a rip or something, I think we'll have an immediate drop in visual acuity. So that's how perhaps, since we are not seeing any CNVM or any polyp, or for that if there is a polyp or branching vascular network, then only we can consider, even if we think of PDT, not otherwise. So I don't think, at least we are not using PDT in a situation where it is a PD, even if it is a tall and large PD like this. So I don't know what is your experience, Dr. Faris and others here. Yes.
Dr. Anura, if there, or Dr. Firas, yes.
Can I mention something? All of us, we have those cases and we are very eager to treat the patient. But I think even if you treat, what visual outcome that you are going to achieve, you will treat the OCT and the patient still is not noticing any difference. So we are treating basically ourselves. We're not treating the patient. The other thing I was thinking that would like spironolactone, those medication, would they help to improve the efficacy and the working function of RV in those cases? I have never I have never tried it, but I was thinking, did any one of you have experience with this or no?
Can I answer that?
We have tried, we have, I'll just mention a point here. We have just tried spironolactone as well as eplerenone in cases of CSC cases, you see. So there it is the different chronic CSC. It's very erratic. That also the evidence is so low and we are not very happy. We don't get much results. And here as such also, as already Dr. Magdi also mentioned earlier, it is the pumping failure because we have such a huge thing sitting there. So I don't think we are improving anything there by giving any of these drugs, and they need to be given for a longer time and they may itself have side effects. So I don't know what Dr. Magdi is to say about this.
I would like to thank her for that question. That's a very good question, very good thinking, because this is a non-invasive way to release the sensory attachment, Dr. Noura, but I tried in my case for 6 months. It didn't work. It didn't work. Second thing, the question was PDT and micropulse. Can I answer that in a different way? I mean,
yes.
Why to do PDT? We all know PDT is a dye, will be absorbed, and then will we expose the patient to something to absorb this dye in the vessels. There is no vessels under the RP detachment. There is nothing there. So why inject PDT? Why doing a scar? Why aiming to flatten the RPE? There is no harm for leaving this huge RPE detachment, and the sensory attachment is minimal. So it's not affecting the vision. Again, if we do micropulse, it might stimulate the RPE to absorb the fluid. But if the vision is 6/9 and the fluid is absorbed and the vision is still 6/9, this is not our aim. Our aim is to treat macular edema doing micropulse sometimes, but micropulse is not working in CNV most of the time. In CSC, it works because it stimulates the RPE,
Yeah, but,
so it will
but there's no
absorb.
CMV in this case.
Yes, but there is nothing. So why to put the patient into invasive maneuver like micropulse or PDT while we can?
No,
while we can wait.
I was asking, sure, but I was asking about what Dr. Muhammad said, that if there was a drop in vision, what options of treatment do you have? Well, obviously, there is no need, as you said, there is no need for injections because there's no new vascularization. But
I consider PDT more serious than injection. I consider PDT more serious than injection.
I did not say PDT.
Yeah, micropulses.
No. He's not. Dr. Firas, Dr. Majdi is not replying to his PDT from your side. I asked this question. There is one of our colleagues, he sent this questions or in a chat. So just I mentioned it just to know there is some points came and we need to highlight it, just that. Okay.
It's very good to have brainstorming, very good to use whatever you have. Micropulse will not be that harmful, but again, if you want to try it, you can try it, but even the fluid will be absorbed. Sometimes you will not get anything. But any deterioration of vision, the patient will blame the micropulse at the end.
Okay, Dr. Majdi, there is one question. Now, okay, we agreed that there is no way to treat whatever we can do. So the patient will ask if there is any deterioration. What shall we do? I mean, how we will convince the patient that we will leave him like this? He will tell me, you are leaving me like this.
Yes.
You are leaving me like this without doing anything, and you can just leave to me and I'm losing my vision.
No. The natural course sometimes is better than interference. And this case is this is what I convinced the patient. I followed you up for 5 years and your vision is stable. If it is deteriorating and there is something we have to interfere for, we will, doing multimodal imaging again. If there is nothing, we will watch you because we are waiting for the natural course of the disease instead of losing the vision suddenly. This is a very good answer, very convincing answer, and the patient enjoyed 5 years with a 6-month vision.
Okay, there is the last question maybe about this one in my mind. What is the pathophysiology that's, making this happen? The pigment epithelial detachment in this way.
This is what we answered. I mean, sometimes you get sudden RP detachment, but huge types like this, we face it very rarely. And it's mostly harboring CMV down there. But sometimes it is, we all know that separation from the RPE, from the Bruch's membrane happens because of the weakness of the zonular occludence in between. The protein is weak. So that's why it starts to dome shape and then start to have sensory detachment. But there is no certain pathology to say why this patient get RP detachment, why they are not. In my opinion, I don't know.
Yeah, what has been seen is, especially in the cases of polypoidal choroidal vasculopathy, PCV cases, we find they look like these PDs, just like large confluent drusen. They get together. Like here also, you saw earlier there were like 3 of them, and then it became 1 in the left eye. The same way it happens in many patients when we follow PCV in the other eye. And suddenly we may get as big as I have shown you a PED there, but that soon becomes hemorrhagic because there are already polyps there. So that is different. But then that's how they can form. So we have to watch these cases for a long time. And sometimes we just think that they may be just large confluent drusen. They may not be. They may be like PEDs, which may get ultimately joined together and form a large like this one here. Yes.
Okay, I have one comment. I think this one is from our doctor, Dr. Ahmed Yahya. He's saying long-lasting BED cause retinal pigment epithelium atrophy. That's why better to treat by micropulse. I think Dr. Majdi comment, but we need to also to comment about his.
You see, the question is till the time this PD would last there, it's not going to. So we have already followed 5 years. There is nothing happening. The vision is good. No atrophy is occurring. So we do not understand this part also, why the atrophy occurs. Sometimes the atrophy has been seen after PDT, and atrophy has also been seen once these have been flattened with treatment, and not always. So we don't understand that part. Not all cases would develop atrophy, but finally, what is going to happen with the natural course of with therapy, I think we still don't have an answer. I think we don't like this kind of follow-up will be available for very few cases. So we are eagerly watching what is going to happen next to this case. And we have few more cases. We are now confident that we're going to watch them, and their follow-up is not as long, maybe about 3 years, another 2 patients I have. So we'll know it, we'll have the answer, but I don't think that the treatment will prevent atrophy. Yes.
One more comment before you,
yes.
you move to the next one, to Dr. Ahmed. If you use the micropulse, you are not using the micropulse to flatten the retinal pigment epithelium. The micropulse will increase the pump of the retinal pigment epithelium to absorb the subretinal fluid. But there is no proof that micropulse will flatten the retinal pigment epithelium, because we are not treating what's under the RPE. Micropulse will stimulate the RPE to absorb the subretinal fluid, but you don't wait for the RPE flattening, because micropulse has no role in this. We don't treat RPE detached with micropulse. So this is my point to Dr. Ahmed. We can move.
I think Dr. Ahmed already mentioned he was sending also a question or a comment also. We need also just for let's say the truth what he is saying. He said micropulse can stimulate retinal pigment epithelial function to reduce the fluid. Yes. I think then, so if there is a reduce of the fluid, then will be a flattening of the
no. We are talking about the subretinal fluid, not the sub-RPE fluid. Micropulse will flatten the retina, not the RPE, because micropulse stimulate the pump, not to absorb what's under, to absorb what's over.
Okay. So I think it's all the points is clear. If there is any comment before we move to the next case, Dr. Anora, if you have any comment, Dr. Firas, Dr. Ayman, I think Dr. Patricio, I know you are there. So if someone want to add anything before we move to the next case. Management event, if you can just keep Dr. Ayman with us if he want to participate or share his experience, as I know he's having a lot of experience about that.
So should I start with the next case?
Okay. Yeah, we can go to the next case, and if we have any one of our colleagues, then we can.
Case, next case is totally different. I wanted to sort of have a case which has a very long follow-up, and what happens down the line in such a case. This is a 14 years follow-up of a neovascular AMD treated with all types of anti-VEGFs in both eyes. And I'll just show you the first picture. When he first time came to me, he was a very, very important patient, and again a doctor, and he comes with 618 vision in the right eye and 624. And you can see he develops almost simultaneous wet AMD in both the eyes. And you can see here, and in fact, he was so unhappy, and being again a senior doctor, he's thought that there is something else going on. He's using magnifying lens. But once we saw this, I think this was the era. You can see here the date 2007 in the month of September, 3rd September. And we injected him that time with Avastin here. And you can see this is an off-label drug, of course, perhaps used only in a few countries, but that time this was the only thing available to us. And you can see here from 618, he becomes 6.6 with the first injection itself, how dramatic. Even in the left eye, you can see how much he improves immediately. And he is kind of thrilled that he is able to read, do everything. And this is after even 14th Avastin injection. Somehow he required monthly injection. That was what was going on with him. And I'll just jump over and go straight here. What was happening on autofluorescence? He was trying to develop some kind of these hypofluorescent areas, dark areas here, both eyes. And you can see here, it has, this is the right eye down the line. And you can see this is in 2011. This has become fairly dark here. But you can see, this is the 32nd injection of Avastin, 612 still in the right eye, it is still working. But then it stopped working and left eye became worse. You can see this whole area becomes dark. That means it has developed atrophy. And you can see the atrophy here, although it is still working, but the vision has gone down to 636. Now, I'm just showing you here what has happened now. This is in 2021, January. This is the right eye scar, and he has received each eye more than 100 injections of later on Lucentis and Eylea for each eye. And he himself being a very senior doctor, he came when he was 82 years old. Now he's 96 years old, 14 years later. And you can see the left eye now is just finger, just close to face and very bad vision. But here he's still having something like 660 vision. And we are giving still injections to him. You see, this is when we gave the injection before this is what happens after a month. It comes back. This is later on. So he needs even now injection every 4 to 6 weeks. And he is around 660, huge scar. Why I presented this, you can see this is Jan 2021. This was in December of 2020, after giving in November 2020, because he is still responding. Although the center is still flat, but he himself complains that he feels that there is a problem. And so after so many injections and such a long follow-up, so I just wanted your experience also. You might be having such cases, that how they behave, what happens if they follow your treatment as our patient has followed. So thank you very much.
Thank you very much, Dr. Mangata. Also, again, this another dilemma we'll face so many times in patients with AMD, and most of the time we are telling now we are having a new medications and we are maybe not going to improve your vision, but at least we'll prevent deterioration. But even sometimes you are feeling that you are going back and the vision is deteriorating. I think now we will ask Dr. Majdi, because he is waiting also to ask him. Yalla, Dr. Majdi, let's go.
I'm not waiting. I'm ready with the answer. Thank you again for the case. You know, this guy has prepared very good cases with very good messages. If I have a comment, this patient started to develop atrophy very quickly. Is that right, Dr. Magat?
Yeah, I think not quickly, but they do develop after, I would say, some starts developing around 3 years to 5 years. I mostly keep telling them, maybe you will be good for maybe, if you are lucky, 5 to 7 years. But 3 years, definitely I tell them that if you follow strictly, your vision will remain as good. So that is what I keep telling.
My point here that patients very rarely they develop the same picture in both eyes, but this was unfortunate, and probably he had one eye before the other. But looking at the OCT, I thought at the beginning I'm looking at a RAP lesion, because we all know RAP lesion develop rapidly and they develop geographic atrophy most of the time. So I was suspecting from your OCT that this patient had the RAP lesion, and also the color picture, he had hard exudates, few hemorrhages inside the retina, and you know, it looks like a RAP. That's why I always, when I see a RAP, I warn the patient that the end result will not be good, because in most of the recent studies, 60% of the RAP people will develop rapidly RP atrophy, and they will end up with geographic atrophy. So this is another warning sign again. If you have a RAP, tell the patient that the prognosis is not that good. We keep injecting you. And as I saw in in your case, it was very good management. But again, we will never know who will respond, who is not. And probably we will keep injecting. That's why I always talk to the patient or counseling the patient at the first visit. This is a long life disease. It's unforgiving. It will be for life. You have to stick to us. Once you get fluid, you have to come back. Once we extend, you have to watch yourself. Otherwise, you might lose some vision, and we will never be able to gain what we lost. So again, it's a very good message that sometimes you face a patient like this with bilateral CNV, which is very harmful in this case, because both of them ended up very bad with a disciform scar, as I can see. But again, he did the best thing.
Right eye, especially, I would say, he did very well for 7 years. In fact, he had a reading vision for 7 years, which is in fact remarkable. That is what was surprising. Left eye deteriorated fast despite treating. Maybe, as you say, the left eye, we were thinking more in terms of RAP, not in the right eye. And the left eye, even the need for injection was almost monthly. You know, we know that RAP lesions are like TAP. they leak very fast. So they need mostly monthly injection. So you are absolutely right, and they do scar faster. So that was also our this thing that this is a wrap in the left eye. That's why it scarred so fast, and he had a rapid deterioration of vision as far as the left was concerned. Yes.
Dr. Muhammad, can you hear me?
Yes, Dr. Yeah. Dr. Ayman, yes.
Yeah. Regarding good evening, Dr. Majdi. Long time no see.
أهلين Dr. Ayman. وحشنا والله وحشنا كثير.
Thank you. Regarding the RAP lesion, I haven't seen from Dr. Magnata an ICG or FFA even showing probably the mid-phase, late-phase hot spots. It would be probably facilitating the diagnosis of RAP in addition to the OCT. This is one. The second thing is the last OCT, I've seen some activity. Would you probably consider using brolucizumab in this case, as it's not responding very well to the other activities?
Actually, it is still responding. It disappears totally, the fluid, when we give injection. But he requires again monthly injection. That is the problem.
This is why I'm saying.
And a brolucizumab, I'll be very scared.
Just increase the interval.
No, my question is, I think I'm going to ask you people how much brolucizumab you people are using, because at least in USA, they have stopped using for AMD at this time. They are not using anywhere. The question is, after that Mermin trial, where they, after monthly these dosing, they had a lot of issues and they had to stop the trial. So I'm very much afraid to give to him, because if this is the only eye seeing 660. So my question to him is that if he develops any vasculitis, anything in only one eye, we are not giving in only one eye. We are giving it both eyes, and one eye is not doing that well, then we are giving at this time. That is the way I do, at least, and we do in this part of country in India. So I don't know how much brolucizumab. Are you using monthly brolucizumab? That is my question to you.
I think using brolucizumab monthly is a bit risky, and as you said, he has some vision in his in his left eye, counting fingers. So this is why, if he is not responding very well, as I understood, well, and there is no history of uveitis, there is no history of autoimmune disease. Well, it might be an option just to try and increase the interval between the treatments. He's now, I think, 96, isn't he?
Yeah, he's 96 years. He's
really
grown from 82.
This is very unfortunate.
Dr. Ayman, I think he's still young, please, because this age now, according to the new
I'm not
way,
saying he's old, but I say he's unfortunate.
Dr. Al-Amri is 95 and he's enjoying his life.
Yeah,
so he's
105.
He's 95 and he's fine. Don't say old. He's 95 and he's fine.
But Dr. Ayman, I think, but I have one comment regarding the using of brolucizumab. We are using brolucizumab, and I think, and also this comment about Dr. Mangata, they stopped. No, they didn't stop the using of brolucizumab. They are still using the brolucizumab, but they stopped. Maybe you are talking about the study that, but they saw on
another. He's talking about the Merlin.
Merlin, which is, I mean, it's the reason for stop is something different than it used as medication for treatment AMD. And there is, from my primitive experience, there is a very, very nice response of drying the macula, let's say. Even sometimes we find a very good response in the visual acuity. And also at the end, also, if you have a medication like that with an interval of 3 months after the 3 loading dose, it is a very nice. I mean, I have several cases, which is very small number until now, but I didn't find, thanks God, no any inflammation or any complication that we found. And at the same time, they are gaining a good visual acuity. And the drying, which happens within 1 week, and you can imagine sometimes you are giving 10, 7, 8 injection. There is no complete dry. Yeah, there is some decreasing, but you cannot see the macula in the normal anatomical. But I think when you are using a brolucizumab, I mean, in what I have seen until now, it was a very nice and great. I'm not talking here, I mean, I'm not, I don't have any financial interest, but I am talking about my small experience. So just to make our discussion in that track. And regarding your case, Dr. Mangata, I don't know if there is any other comment. Dr. Firas, Dr. Noura, Dr. Ayman, if you are still, and Dr. Musa Majdi. Dr. Majdi, if for this case, what he is showing here, do you think, I mean, what is the solutions if after all this 100 injection and we are still suffering and the patient is still suffering, and even forgetting the age, it can happen even for those they are still in 60, and you can face the same problem, I think, or the same result. Dr. Mangato or Dr. Ayman, or Dr. Majdi, both of you.
I will give you my opinion. Telling you the truth, 10 years ago, 10 or 12 years ago, we used to tell the patient with CMD, you have nothing. You can wait until the natural course and you get a disciform scar. Nowadays, we have the way to decrease the burden from the patient, but again, the natural course will take its course. So again, we are keep injecting, and I'm with Dr. Mangata. Once any drug is working, don't switch to another drug. So he's working with one drug, it's fine. Yes. He should continue the same drug. Even the Novartis people say now, keep injecting your drug, whatever, ranibizumab, Avastin, whatever, keep injecting. Once you get fluctuation or rapid recurrence of fluid, you can use this, and this is a very good explanation of any complications happen to the patient. So my opinion, if the patient is responding, even Avastin, keep injecting Avastin. If he's drying up with any drug, keep injecting this drug. But again, if he is not, he can switch to another drug. And again, the guy did the best choice because it's the cheapest, it works, and it gives the patient the maximum benefit. And as Dr. Ayman said, there is fluid coming back, but as long as it is responding to Avastin, keep injecting Avastin. If it's not, change to ranibizumab. So again, it's a very good choice. We can I think so. If it's ranibizumab working, don't switch as long as the drug is working, because we all know ranibizumab for 12 years now, 10 to 12 years. Without
14, I think now 14, right?
Yes.
From 2013,
he's now on ranibizumab. He still does very well with the Lucentis injection.
Why to switch to another drug and
no,
get
we
the
are
hazard
not.
sometimes?
That's how we are not switching.
This is my policy. I totally agree with what Dr. Majdi said. If things are working with Lucentis, with ranibizumab, I wouldn't change to brolucizumab. Definitely, I wouldn't.
I don't think, Dr. Ayman, I mean, everyone, I think we are doing all the same. We are agreed about this one. I mean, we are not changing or switching unless there is no response of the treatment. Otherwise, we have to continue.
Has a suboptimal response, or is not responding anymore. Yes, I would think of changing to brolucizumab. It's a very good drug. And regarding the USA, they stopped the Maryland study, which was a monthly injection of brolucizumab due to increased vasculitis, but it's still used everywhere, and the results are very encouraging. If the patient selection was right.
Okay. As we are discussing the AMD. Yes, please go ahead. Yeah, we are waiting for you, Dr. Wallah Firas.
I think this case opens up a very good discussion about patients counseling. I think sometimes we simply, as sad as it is, we just lose the battle, and patients will start losing vision. I think initial patients counseling is very important, and we need just to explain to patients initially with wet AMD that the main reason we're injecting them and treating them month in, month out is to stabilize the vision. That's our aim of the treatment. If the vision improves, that's brilliant. But our aim is to just maintain what they've got. And even when they start, the AMD start to get worse and the fibrosis start to happen, the injection is just to minimize that black spots in the center they have and just to keep it as small as it is. So I think in these kind of cases, patients counseling is very, just open up the discussion about patients counseling, because sometimes we get lost in the mayhem for our clinics and we just get our patients into injections. But coming back to basics, I think patients counseling is very important talking to them about the aim of the treatment and what our initial hope this treatment can achieve.
Dr. Firas, as you are talking about this counseling, how do you talk with the patient? I mean, this is very important. We are, facing this problem. Sometimes it's very difficult to tell the patient, see, before we used to say, see, this is the disease you are facing and we don't have anything to do. And we are just waiting. I mean, you will tell him that the natural course of the disease, and then maybe one time, we don't know when it can happen, that you will lose of vision or you may end up with blind. Now we are talking, there is we get more drugs, and but still, if you are thinking about that, we are still also in the same area. There is some improvement, but maybe we are, so let's say in the other word, delaying only the natural course. So how you are pass the message to your patient, how you are doing this?
Well, I usually just explain to them how serious the situation is, that this is a condition. We do not have a cure for it. Everything we're doing is just to maintain and stabilize the disease. So
sometimes this one, it will make the patient will be, it will be like a psychological trauma sometimes, if you think about it, it is, you can't tell the patient you are going to blind. If I am in that place,
no, we're not.
It will be a very difficult something to hear this.
Well, that's what I say. You do not go blind, because they will not go blind from this condition. The central vision might be affected and might be affecting in a very serious way, but they're not going to go blind.
Hand movement is a blind, it's
legally blind. But
for the patient, we are talking about the patient.
I know.
He cannot see what he is going to do when he is having only hand movement. It's a blindness.
It's always important to explain to them, to show them the brightness of the whatever darkness they have. Is that although the central vision might be affected, but their peripheral vision will be there, and that would mean they will not be dependent on other people's and their daily activities. And that's what I explain to patients, even in those patients that they come late, that although the central vision might be affected, although the reading might be affected, although writing might be affected, but at least their peripheral vision will not from this condition. And that would mean that in daily activities, they will not be dependent on others. And that's very important. So, and the other thing we need to mention to them, that they must know that we do not have a cure for the conditions. Everything we're doing is just to maintain and stabilize what they have. Sometimes we get improvement, that's brilliant, but others, and the vast majority, it's just to maintain. And it is a long treatment. There's no cure. They're going to keep coming. They need to maintain their appointments, and they need to always be aware of any sudden deterioration. So there's part on us to arrange their appointments and to follow them up in our clinics and be prepared to treat them, but it's their part to test themselves every now and then between their appointments, and they suffer any sudden deterioration or distortion in vision, they must come back immediately. So that's how I do it.
Thank you, Dr. Firas. Dr. Nora, if you have any comment or any questions.
I have just one comment. Thank you for presenting this interesting case, Dr. Degra. The other thing, I think by treating those patients, the scar will develop anyway, but I think we are giving them the chance to maintain good vision for the remaining years before they develop the scar. My question, do you think BioView will help to delay or prevent those scars from forming? Do you think there is a role? Because I think it's more stronger medication. Do you think it will affect? I'm sure there is nothing published about scarring because it's a new medication.
I think, yeah, Dr. Nora, I think we have even 7-Up study and so many other studies where it has been seen that the more drying cause probably quicker scar formation. But you see, the question is what we are trying to say here is, and everybody has said that, as the aging and this is the chronic disease, it's not going to get cured. The scarring would happen. But even in 14 years, you can see here in the right eye, the scar is small. That is what we are achieving. But for 7 years, he had a good reading vision. So that is what is very important. So we always tell 5 to 7 years, if you come early, you may have as good a vision what we are giving now. If you regularly come for follow-up and the injections you receive. And as far as the scarring is, we always tell it is going to happen. So that's why we tell 5 to 7 years are good. Then the scar would happen. And I have shown in this particular case that after 7 years in the left eye, there was a significant scar. So that has been seen even in the 7-Up study. And it was much more in cases that they compared that time, perhaps the ranibizumab developed more scar because of drying more as compared to the other drugs that time. So that is what was happening also. Yes, you're right. But most important to me is that we limit this discomp spar, we form it very small. And so even after 14 years, I mean, he demands injection every month because he develops something and symptoms that no, he's not seeing as well, even if it is 660. So that is what I think. If you have such a compliant patient, they'll do very well. Absolutely. And they'll never go blind. Of course, we always tell them they'll never go blind with AMD. That is very important. Dr. Emery has said that. It's very, very important for us to give that message.
Doctor, okay, if the patient came and early, do you think there is a difference if we start the early management from start late? Even if sometimes, one patient, he came only he's having in one eye, the other one is still not. So what to do? Just to observe and or we have to interfere in one way or another? Is there any other options that is not only for anti-VEGF? As we are discussing the AMD, there is a lot of methods came and the era of treatments, many things, and there is many publications about different way of treatment before laser now. So many things tried. So what we can do if the patient is, now we are seeing that patient is having one eye and is deteriorating, the other eye is good. So the patient is asking what will happen to my eye, the other eye, which is still now good.
I think it's very important question that happens very often, that we have one eye which has gone bad and other eye of patients is very, very scared. These days we are also seeing, and it has been reported, we have also seen ourselves, even if it looked like a non-exudative, we find a membrane on OCTA once we do it, and it is not leaking. So the question is, at this time, nobody is advocating treating them, but we'll have to keep a very close watch there, very, very close watch. Even if there is a little fluid, especially intraretinal fluid, if it is coming, that is more damaging than the subretinal fluid. We all know that. And so I think we have to then tell the patient, you are one-eyed, we have to treat it very aggressively. We don't want even this. And there's another one. If we give a PRN treatment and like we keep on waiting for that fluid to come back, the damage is much more. The scarring is much more. If we put them on some kind of a protocol, which is like a treat and extend or something, where we don't let this fluid accumulate again and then treat, I think they would last much longer. So our treatment approach there would be much more aggressive. So that is my answer to what Dr. Emery asked. Yeah.
Dr. Majdi, if you want to comment. Dr. Majdi, you are there? Dr. Ayman?
Yes, Dr. Muhammad, just to add to what my dear Dr. Dogra said, is definitely I would start by doing a baseline fluorescein angiography for this patient. If I feel that this patient needs an ICG because I'm suspecting a PCV or a RAP lesion, I would do it again. Beside the OCT and the OCTA, I will do everything just first of all to make sure of the diagnosis, because the RAP lesion, the PCV have a different prognosis rather than the classic or the occult membrane. So making the proper diagnosis is definitely important. All of us will start by doing OCT and OCTA, and they forget about the fluorescein and the ICG. I think baseline fluorescein angiography and ICG are really important, beside of what Dr. Dogra said about the management. I totally agree with that.
I think there is one more question. Most of us, we know when to start the treatment, but when to stop. I mean, okay, the patient is respond and the fluid is decreased, and do we have to stop, or do we follow as treat and extend, or we have to give monthly? when, I mean, we can stop giving an anti-VEGF? What is the criteria to stop treatment or to make treat and extend if we are agreed if the treatment of extent is one of the methods? Mangata or Dr.
Yeah, I would answer this question first, where you see, once we are treating these patients earlier, that is the time when we don't want them to come with recurrences and then only treat. They will be more damaging. That is where we want to treat them aggressively, whether we give them treat and extend, which is preferable, it works very well for these cases. And I would say when to stop. Now we have left eye in this 14 years old. You can see there's a huge scar. It is not improving any vision. And there'll not be any use giving injection in that eye. So we have stopped giving injection in the left eye of the patient, which I presented maybe about 6-7 years back. But right eye, despite a scar, we are still giving, it is still showing those cystic spaces, and he still feels that it improves. I think till that time, the patient is feeling that it is improving. You feel that cysts are disappearing. I think we will keep on treating if the patient is agreeable and is also convinced that this is working for him. That is the way we follow these patients. And of course, frequency we do have now with treat and extend patients, those who receive 3 monthly, few of them with at least, I know with ILIA, some of them receive after 4 months, especially in some of these PCV cases. Yes.
Okay, I mean, Dr. Dogra, if we are having the patient and there is no fluid and still, and the vision either stable, I mean, you are continue giving treat and extend?
No, we don't. Yes, we modify it. We treat and observe. In fact, in such a situation, what we do is if it is dry and we are finding that at 3 months, when we were injecting it 3 monthly, if it is still coming like we do in between OCT, and look for, it's not that every time we keep on injecting what they say in. So we also do a little modification, which is treat and observe. So we do OCT in between. And if we find, no, there is no fluid coming, we give another month. That's what I'm saying. And if already it is dry for 4 months, maybe then we want to give them another 2 months. So we do have some patients, but they usually will come back sometimes. It is also very much there that they may come back, but there are very few, very small numbers where if it has scarred and the scar is small, maybe they don't form a new choroidal neovascular membrane, but their number is small. Most of them, they need injection long term. Yes.
Okay, I think we need maybe to continue about this one, but can we have Dr. Tahra, and she is, I think Tahir or Tahra, I don't know, sorry for that, but I didn't get the name correctly. So you can open for her the mic and keep, okay. Dr. Majdi, I think you need to comment. Or Dr. Ayman.
Yes, I think AMD is a lifelong disease, so you have to follow up this patient for life. This is one. Number two, whenever I treat and extend, definitely whenever I can extend more for these patients, I extend. I have patients even on Avastin that I could extend up to 4 months between injections. I've been following these patients for years, in fact, and I managed to make the intervals 4 months. This is number one. Number two, some patients, they might still have some subretinal fluid and their vision is stable and they are not deteriorating. Be careful in injecting these patients too frequently because you might lead to macular atrophy in these patients. If the patient's vision is stable with some subretinal fluid, although we are eager to dry all the retinal layers from fluid, but some patients, they still have some subretinal fluid, which is not affecting their vision and they are stable. Just be careful, cautious, not to overtreat them and end up with macular atrophy. I have one patient ended with macular atrophy because of frequent injection like this.
Dr. Ayman and Dr. Dogra, but I mean, if you are giving the patient after 4 months and you are still seeing the patient when he is coming to you and he is dry and the vision is stable, so now you will increase or you will stop or you will I mean, now you are already giving treat and extend,
What
and
I
you reach to
do,
the maximum, which is 4 months, but still you are seeing the patient, there is nothing happened. So
what
here,
I
yes,
what
doctor.
I do myself at this point, I bring the patient at his visit and I do an OCT. If his OCT is still dry, I would not inject, definitely, and I will do this every visit. If there is any sign of activity at that visit, I would re-inject these patients.
So
But
now you are moving from treat and extend to another way, right?
yes, it's a I modify my treatment. Definitely, you need to modify your treatment.
After how long, Dr. Ayman? I mean, how many times you have to treat to see this patient dry? I mean, if you see 2 or 3 visits with every 4 months, for example, 1 year, then after that you go.
Telling the truth, my experience with my patients were not less than 4 to 5 years of follow-up. The patients in their second year, I haven't reached this fortunate interval. I've reached this with my patients after 3, 4, some of them after 5 years of treatment. So, as I said, it's a lifelong disease. You have to follow these patients, and if you can extend, if you can decrease the burden of injection for these patients, go ahead and do it. I have this real example of some of my patients whom I succeed to go up to 5 months of interval. Even some of them were on Avastin, not Eylea.
Okay, I think we have Dr. Tahira Al-Mahmoud. Dr. Tahira, marhaban. Can you open the mic for Dr. Tahira? Dr. Tahira, if you can open the mic, and we are. Okay, till we get Dr. Tahira. Dr. Majdi, are you still with us? Are you there? Dr. Majdi Musa? Okay, Dr. Noura or Dr. Firas, if you have any comments, please.
Can I just, I'm sorry, can I just jump in here and
yes,
talk
please.
about treat and extend thing? I think it's worth mentioning, and it's worth always remembering why treat and extend, in my opinion, and that's my only opinion, why it all started. I think all these things started in Europe, where you have very difficult accessibility to hospitals. You need to, what they found out that they needed to lower the burden of their follow-ups and injections. So instead of seeing their patients every month, they start to have this treat and extend. So you bring patients in, you do the loading dose, and then do treat and extend. So you lower their visits to hospitals from like 12 visits a month to by 3 or 3 visits. That's why, in my opinion, treat and extend started. And it was provided by companies, because drug companies, they found it a brilliant way of maintaining 7, 8, 9 injections a year without looking into diseases activities. Now, I think in AMD, it must be a very tailored approach. Some patients, they're having difficulties coming to hospitals. Others, they can come every month. Others, you can see that they will report back to you whenever they have the slightest deterioration in their vision. Those you can safely, or at least you can explain to them when to come back, and then you can do it as a PRN. Because even when my colleagues, they said about this modified treat and extend, well, basically it's a PRN treatment. So in my opinion, then you can, it must be a tailored approach. So when you have a patient, he will understand when to come back, and he's having no problems coming back to hospitals, either by, in our part of the world, by insurance or whatever. It's easy to tell them to come back to you, and there's no need for treat and extend. Others, you know that they will not report back to you whenever they have a problem. You know you're not going to see them every month or every 6 weeks or whenever. Then you may consider treat and extend.
Okay, Dr. Firas, how do you manage? I mean, if you feel this one is it's one way of the method of treatment, whatever the reason behind, it's applicable, or you believe on BRN or a continuous treatment?
Well, I myself, I go for treat and extend for the first year, because this disease is different from DME. This is a new vascularization with risk of bleed. So when you have a bleed, you have fibrosis. So it's better to, even if you overtreat, you're going to overtreat by 1 or 2 injections. It's better to overtreat than undertreat in these kind of conditions. And we're not talking about one simple presentation or one patient we're presenting
So you are checking for every patient at different.
For the first year. Yeah, well, I usually have tailored approach, but in the vast majority of my patients, it's treat and extend for the first year.
Okay, for how long you will treat and extend? For how long?
By 8 weeks. 8 weeks.
8 weeks.
At the end to 8 weeks. Yeah.
Okay. I think we have Dr. Hassan. Yes, Dr. Noura. We are having just Hassan is there, Dr. Hassan and Dr. Dr. Tahira, if they are available. If you can open the mic for Hassan or Tahira, the management event, if they can open for both of them, please. Okay, Dr. Noura, yes, the mic with you, please.
I'm a big believer of treat and extend treatment for those patients, because they are a lifelong treatment, and we need to help this patient to receive the proper treatment and the regular follow-up for them. So because you will keep injecting, and I don't think it's feasible to do like regular treatment for those patients, or to bring them for regular PRN treatment. So I am a great believer of treat and extend. And most of the study, they confirm that treat and extend, they tend to have a better visual outcome other than extensive treatment, regular treatment, or PRN treatment. The other thing, I usually extend for 12 weeks.
Okay, Doctor, the question is, after a long period of, for example, treat and extend, and you are treating for every 12, let's say weeks, 3 months, then you find the patient, he is stable and the vision is not deteriorating, no fluid, then what are you going to do? Are you going to continue still, even you will continue every 3 months as a treat and extend, or you will stop?
So if it's a single eye patient, I might consider continuing doing 12 weeks. I might extend it a little bit, but I will never stop.
You will never stop. Okay.
If single eye patient.
Can I make a comment?
Yeah, we are waiting for your comment.
I lost the connection for 5 minutes, but I came back.
Okay, Dr. Noura, you allow Dr. Majdi to comment, or
yes, sure. Go ahead, Doctor.
Because
there is nowadays what we call treat and extend and exit. So treat and extend up to 12 weeks, 16 weeks is the maximum. And then sometimes you follow up the patient, as Dr. Madanat was saying, sometimes you follow up the patient, it's fine, it's completely dry. So I do exit at that time. I keep watching the patient. If he's dry, I would not inject anymore. And
then how long to follow? How long to follow?
Yes,
then
after
that time
16 weeks, you inject and he comes back after 16 weeks. If he's dry, I would stop injection and see. 16 weeks is the maximum.
Then when you are going to bring the patient to follow up, you stop now, for example, So next visit,
I don't wait for another 16 weeks. I used to do 8 weeks and then 12 weeks and then 16 weeks. And if the patient is dry, I don't think he will get wet, or maybe he will keep couple of 3 years up till now. But there is treat and extend and exit. Why? Because sometimes you are afraid of the geographic atrophy. This is very, very important thing. But sometimes I found in my patients that I do extend, and I did extend up to 6 months in one of my patients. Then after 6 months, I stopped injecting and he was fine. But I keep him under my observation, or I give him Amstelville and tell him any change in the vision, you should come back. But treat and extend and exit is a very good and very acceptable protocol nowadays. We are afraid of over treating sometimes, but sometimes you would know this patient will never be dry. Like the patient Dr. Magata showed us, he will never be dry. So this patient has to be injected for life. But there are some patients who need minimal injection and they found that they are completely dry. So again, unresolved mystery in this disease, and you'll never know who will respond, how long he will respond, and how long you can keep treating this patient.
Dr. Majdi, as you are now you are with me, how about PRN? I mean, Dr. Firas, he mentioned also about the using of PR treatment.
I mean, I started with PRN, and I used to do PRN most of the time, but nowadays I treat and extend. Because PRN, I have to bring the patient monthly. This is very, very difficult for the patient. So PRN, I mean, sometimes he comes back with a very high level of fluid, and I will never gain what I lost. So in AMD, I always do treat and extend. In diabetic macroedema is completely different. PRN is my role. So here I do treat and extend.
Okay, what is the take-home message? Okay, Dr. Ayman, yes, please.
It seems that me and Majdi have the same experience. As I said, I managed to extend some of my patients up to 5 months. It's not when I said a modified treat and extend, it's not a PRN. No, what I mean is that the patient, if I'm positive or succeeded to extend him up to 4 months, he should come after 4 months, unless during this time have any problem, any loss of vision, he will come back. But I used to bring him after 4 months. Some of my patients, if they are still dry, I used to extend them up to 5 months. When Dr. Majdi said exit, we don't exit patients. We don't mean that patients do not come to the clinic anymore. No,
yes,
we don't inject them anymore. This is
Yes,
what
yes.
we
understand
treat and
that
extend
from
and exit injection. That's
exact injection, not exit treatment. Sure.
We exit the injection. We don't exit the patient himself. So whenever you can extend patients, even after a few years, 3, 4, 5 years, you know, it's a burden to keep injecting them if they don't need that. And you might end up with geographical atrophy or microatrophy. So if there is no need for injection, just keep extending, keep extending.
Thank you, Dr.
Thank you,
Ayman,
Dr. Ayman. Thank you
for explaining this, because there is no exit for this patient, but treat and extend and exit injection. This is a very good point. I'm sorry I didn't clear that up. Thank you,
it
Dr.
was
Ayman.
very clear, Dr. Ayman, Dr. Majdi. It's very nice. Nobody can exit the patient or the treatment.
But the patient can exit from life.
That's something different, not in our hands. This is something else.
This is what happens sometimes.
Yes.
Okay, thank you very much, Dr. Majdi. If you have to give, I mean, a conclusion, Dr. Majdi, about what we are discussing during the about 1.5 hours now about AMD, what is the most important take-home message for all our colleagues that are listening to us?
In a few points, number one, it's a long life disease. There is nothing called leave the patient. He had to be injected till he's dry. Once you have a drug working, don't switch to any other drug, because we don't have many choices. And always counsel the patient at the beginning that this is a long life disease. You must be injected for life. You might not need more than 3 injections. You might need even 1 injection. There's a recent paper, by the way, a couple of days ago, saying that some of the patients injected once in their life and they never had injection again in 10 years. And this is very peculiar. I just read it yesterday. So again, counseling the patient is very important. The ideal message is treat and extend. And this is very good to tell the patient treat and extend. Tell them this is for you, this is for us, and this is less burden for you. So this is my take-home message. If any of the other colleagues, Dr. Madana, Dr. Mangata,
yeah, I am going to listen for
something.
all of them now. Yeah,
Please,
Dr. Mangata, please.
I think I'm quite happy that there was a good discussion on the cases which I presented, and that formed sort of a platform. And one thing good here is the majority is for the treat and extend. And I think treat and extend is the way to go in cases of neovascular AMD, so that we have all understood. And being a lifelong disease, I think we have to also modify according to the patient's needs and how the patients is going to be sort of coming back to you. So sometimes we have to do modifications which are different from that. But if we can, I think the treat and extend is the best way to go. Yes.
Is there any, okay, just before we go that, can we ask the management, please, if you can, please put the link for certificate of attendance in the chat, so all the participants can get their certificate. Please don't leave before you take your certificate if you want to take a certificate. Okay, so from the Marvision team to everyone, the link is there now in the chat if one want to take his certificate of attendance. Very nice, Dr. Majdi, at the end that we see you live. Before we are
I
only
told you, I
but
told you I have to go out to make that lecture. Otherwise, I would be trapped at the home. There is no electricity. So I told you, I am in the, I told you. No need, but thank you so much. Thank you, Dr. Maganet, for these nice cases. Very,
Thank you.
Very
Thank
very
you.
illustrative
yeah,
cases.
it's very
Thank you so
nice
much. We
as
enjoyed it.
always.
Yes.
You know, I'm
Yes.
all the time
Thank you.
waiting for Dr. Mangata for his case. As usual, he is presenting a very interesting case. He's a long
you.
experience, even still he's young. You know, I want to
Thank
mention
you.
this very
Thank
clearly,
you.
Dr. Majdi, especially for you, Dr. Majdi.
Thank you.
Thank you, Dr. Emri. Thank
Dr.
you.
Ayman, if you have any things, and Dr. Noura, Dr. Firas. So I give everyone one thing.
First of all, Muhammad, thank you very much. It was really a very interesting session. I really enjoyed Dr. Noura, Dr. Firas, and Dr. Mangat presentation. And it was really nice to see my dear friend, Dr. Majdi. Long time no see after this corona epidemic. But one thing just to stress on is the safety of injection. Always use a speculum, always use betadine solution. Do your injection in a sterile environment, and always tell the patient to come back if he has any pain, new redness, or new floaters in his eye, because safety in these cases is very important. Thank you very much.
We are having the link is there. Please just go up and down. You will find the link. I can see very clearly. Go up and down, then you will see the link. And it's posted twice, not only one time. Dr. Noura, if you have anything at the end to say, and Dr. Firas, please.
Thank you, Dr. Muhammad, and I'm very glad to be among you, Dr. Mangata and Dr. Majdi, with great, huge experience in the field. And I really enjoyed the discussion with all valuable points, and my opinion is the same to yours. So it's taking care of those patients, explaining and doing the proper treatment for the patient to help the patient gain their best vision for the remaining period of the disease progression. And thank you so much, Dr. Muhammad, for the invitation. Thank you.
Our pleasure, Dr. Noura. Our pleasure, Dr. Noura. Okay, Dr. Firas, please.
Well, first of all, thank you, Dr. Muhammad, for the kind invitation, and thanks for everybody, for Dr. Magna, Dr. Magdi, Dr. Ayman, of course, Dr. Noura. So it's just a final takeaway, as everybody else saying, just take some time in the first visit with patient counseling, spend more time in the first visit, explain to patients what is disease, the prognosis in the future, that will save you time in the future. And just tailor your approach to every single patient towards their needs and their circumstances. Thank you very much again.
Thank you very much for all of you. Before we move and we close these sessions, it was very interesting. I learned a lot from you, and we highlight a very important points. Maybe it's sometimes you are in your way or working and your experience, but sometimes you forget some point. Just thank you for Dr. Mangata, Dr. Majdi, Dr. Ayman, Noura, and Firas, and all our colleagues who participate with us, even the comments coming from the many of participants. And before we move, I just want to remind you about next week. We are waiting, and we are delighted, and we are excited that we are going to have the third MEOM conference for 3 days. It will be a virtual platform on the Zoom, and we are having more than 150 international speakers and covering all the subspecialties. I want to mention this very clearly. It's a free registration, please. Free registration. There is nothing. Just you go and register, but please register as soon as possible, because we are having a limit number by each sessions. And also we are going to have a CME accreditations by this for this conference. And I wish that you will enjoy with us in this meeting. And as you enjoy, I hope that with our meeting. Thank you for the Novartis for sponsoring this meeting. Thank you very much, Dr. Mangata Dogra. You are always there, and thank you for your time. And I know we delay you now. It's almost 12 midnight. Dr. Majdi, as usual, we are learning a lot from your experience. Thank you, Dr. Ayman. Actually, I was planning to invite you, but I feel shame to invite you. I know the circumstances you are now there. I want to pass my condolences on behalf of my colleagues for passing of his, I think, brother. I would like to thank you, Dr. Nora and Dr. Firas. Thank you very much and good night, and see you, inshallah, next week in the conference.